análise de banco de dados, database analytics e inteligência artificial, avanços na cirurgia robótica e navegação, e o último, o futuro da cirurgia da coluna na visão 4.0, ou seja, para a quarta década do século XXI. O mais importante dessa abertura é que a gente consiga entender o funcionamento da plataforma. Então, a gente, para cada final de apresentação, a gente vai abrir a opção levantar a mão, raise your hands, e essa é uma opção em que o attendee, né, quem está na plateia, pode fazer uma pergunta direcionada verbalmente direto para o palestrante. Então, se existir um interesse de alguma pergunta direta, por favor, use essa ferramenta ao final das palestras e a gente vai abrir a voz daqueles que tiverem interesse em perguntar. A ferramenta bate-papo não se destinará a perguntas, a gente só vai usar ela realmente para bate-papos não dentro dos tópicos e que não vão demandar respostas específicas, e a ferramenta Q&A, é a ferramenta que a gente vai usar para responder as perguntas de texto direcionadas a cada uma das palestras. Mais uma vez, é importante lembrar que esse é um projeto que o BSSG e o IPC fizeram para levantar fundos para entidades filantrópicas voltadas ao combate do Covid, e que a Fiocruz é a entidade que nós elegemos para essas doações, e a gente pede para que todos aqueles que puderem colaborar com qualquer quantia através do escaneamento desse QR Code, para que a gente possa fazer um pouquinho da nossa parte na tentativa de mudar esse cenário. Então, essa é a introdução inicial, vou passar para os moderadores, a gente vai dar início às palestras o quanto antes para tentar nos manter no programa. Obrigado a todos mais uma vez, thank you all for the participation, thank you Bill, thank you Roger, Maria, o Ricardo, que eu não vejo aqui presente, o Guimarães, mas também deve estar entrando aí em alguns minutos para se juntar conosco. Obrigado pela participação de todos e vamos dar início ao programa.
All right, Rodrigo, should I get started?
Yes, please.
All right, great.
Yes, you're the first presenter. Provavelmente muitos dos que estão presentes conhecem o Dr. Roger Hartl. Dr. Roger Hartl é professor da Weill Cornell em Nova York e do New York Presbyterian Hospital, e é um grande pesquisador e um ícone da neurocirurgia, da cirurgia da coluna mundial. Acredito que a grande maioria de vocês o conheça. Ele, para o meio acadêmico e para o meio de coluna, dispensa apresentações, mas para aqueles que não são, realmente é uma grande oportunidade. So, just presenting you, saying that you are a icon for spine surgery, and a big researcher and a great name, and we are very glad to have you here. Thank you, Roger.
Rodrigo, thank you very much. Everything I know, I learned from Luis, okay? And it's a real pleasure to be here tonight. Thank you for asking me, Rodrigo and Gabrielle, who's been emailing me, and Luis and the organizers. Thank you very much for having me. I'll try to share with you a little bit of my experience with biologics for spinal disc regeneration, repair, and replacement. Part of this will be research. I know that you have been, you have had a very, very busy curriculum for the last weeks. And I think it's amazing that you decided to include biologics for not only for fusion surgery, but also for disc regeneration, because I think that this is a really important topic for spine surgeons to get involved with. These are my disclosures. And the idea is really that by using biologics for disc repair and disc regeneration, we're trying to avoid the cascade of events that usually happens in our patients, where patients have back pain, a degenerated disc, then they may end up with surgery, they have disc degeneration, further problems, they come back, they have fusion surgery, and then adjacent level disease. So there's a cascade of events that results in an incredible number of surgeries being done every year in North America, but certainly also around the world. I mean, in North America, we have about 1.5 million spine surgeries a year, and almost half of those are fusion surgeries. And the question is, well, is that really necessary? Do we really have to go down that pathway in our patients? Or is there something that we can do maybe early on when patients first present with back problems in terms of regenerating or repairing the disc to prevent the progression to further significant spinal problems that may result in fusion surgery or even multi-level fusion surgeries? And the idea is really, obviously, if you look at a lumbar spine, you see a healthy disc, you may see an adjacent disc that's not so healthy. And so even in one patient, you can see the whole sequence of events evolving over time. And if you don't intervene early on, and the intervention could be, like I said, biological, physical therapy, healthy lifestyle, and so forth, you see that progression where patients then go on to needing either fusion surgery or maybe disc arthroplasty or some kind of fairly aggressive surgical intervention that then may have other side effects itself. So the problem is really degenerative disc disease. And is there something that we can do to prevent the progression or even the development of degenerative disc disease? There are certain things that we can't, that we do not have an impact on, such as genetics. We all get older, unfortunately, except for Bill Smith, who looks like 10 years younger than last time I saw him. You know, smoking, mechanics, and so forth. So all these things, we don't have an impact on that. However, we have an impact on lifestyle and potentially on interventions such as biologics, which I'll talk about. The human spinal disc is a very complex structure. It is wedged in between the bone above and below. There's complex vasculature. As a matter of fact, the disc itself doesn't have any blood vessels once you're an adult. Interestingly, there's innervation of the disc, and studies have shown that if you have degenerative disc disease, especially if you have painful degenerative disc disease, there's actually more innervation as you get older, which is probably one of the reasons why discs can cause pain as they degenerate and as people can get older. And then there's a very important feature to the disc, which is really related to the anatomy, which is the nucleus inside and the annulus fibrosus outside. The healthy nature of the disc depends on the integrity of the annulus fibrosus. And that annulus fibrosus has a tremendous capacity to contain pressure. People have studied this. This is a study that was done in Germany many years ago, where they implanted transducers into this was a healthy volunteer, and they put a small probe into the disc and they measured the pressure with that particular subject standing up, bending forward, lifting up a box of beer, and the pressure goes up tremendously. And that all depends on the healthy nature of the annulus fibrosus. So, and then you can test the integrity of the annulus fibrosus by injecting dye into the disc. This was done here. So these are discogram, and you can see at L5S1 that disc is injured. There's leakage of that dye into the spinal canal, which tells you that there's a problem. And this patient had back pain because of that. Now, if you look at the quality of the disc and you look at the stage within the cascade of disc degeneration, there's an early, intermediate, and advanced stage. And theoretically, we can intervene at different time points with biomolecular, cell-based, or engineered constructs using biological treatment interventions or tissue engineering. And I want to talk to you about, really, I want to talk to you about three things. I want to summarize for you briefly the status of research and clinical trials for three different things. The first thing is that patients who have low back pain and disc degeneration, who never had surgery, but where investigators have tried to treat that by injecting stem cells, and I'll share some of those results with you. The second part of my talk will be on lumbar disc herniation and how surgeons or individuals are trying to prevent recurrent disc herniation and further disc degeneration by treating the annulus fibrosus in the operating room. And the third one is experimental, is really total disc replacement using biological implants. So the first one is, I want to summarize a few studies that were done on patients who presented with low back pain and disc degeneration. And what a lot of investigators have done over the last 10, 15 years is they try different types of cells that they harvest beforehand, and then they inject into those patients in the procedure room, in those patients who have a degenerated disc and where that degenerated disc is causing the low back pain. And I think the most promising studies, promising meaning in terms of the results, but also promising in terms of how you can actually do that in the operating room effectively and realistically, I think are studies such as these ones here that are listed here, where patients come to the procedure room and they're sedated, and the physician harvests stem cells from the iliac crest, and those stem cells are sometimes spun down to increase the number of cells in the fraction of cells in the volume that's being injected into the cells, and then the physician injects those cells into the disc. Sometimes these discs can be harvested weeks before, and they can be cultured, and then those patients come back later on for injection into the disc. It turns out that the best results that and these are all pretty early studies. You know, none of this has really been done in a prospective randomized fashion, but very promising results have been obtained in patients with low back pain who have these discs, these cells injected right then and there without having those cells really cultured. So this is a study that was published in 2015 where the investigators harvested bone marrow derived stem cells and injected them right then and there into those patients' spine. And they saw in a dose-dependent manner, they saw regeneration of those discs and also MRI findings that indicated rehydration of those discs. And there was a beneficial impact in these studies in terms of low back pain. Now, again, this was not randomized, this was not blinded, these are just observational studies, but they kind of pave the way and they kind of show us going forward potentially where we could go with this. Another study that was very interesting is an ongoing trial actually now with Mesoblast. It's a commercially available mesenchymal precursor cell that is injected into the disc of patients who have low back pain. There's a phase 3 trial currently ongoing that's supposed to be completed by 2021. And the phase 2 trial was done in 100 patients and showed, again, a dose-dependent improvement in these patients' back pain at 24 months. Again, we need more. Obviously, we're all awaiting the completion of this trial. Hopefully, this will be very interesting to see. So, second, I want to talk to you about lumbar disc herniation. What is it that we can do? What is it that we can do to? Hold on one second. I'm sorry. You got to stop. Tom, can you? All right. I'm sorry. So she's cooking. I'm sorry. Can you just stop cooking? All right. She's not listening. Sorry. Anyway, I'm looking forward to a nice dinner later. Can you just stop? Just be quiet. Doesn't can hear that. So the second thing I want to talk, I'm going to be in trouble later. I'm sorry. The second thing I want to talk about is the lumbar disc, so annular repair. So when you perform a lumbar disc herniation in these patients, there's a risk of a recurrent disc herniation, and there's a higher incidence of low back pain in these patients, even long term. And we've looked at the literature. If you look at the literature, the overall risk of a recurrent disc herniation in these patients is about 20%. The chance of having chronic low back pain, even 10 years after surgery, is between 30 or 40% chance. So if you have a lumbar disc herniation, whether you have surgery or whether you have non-operative treatment, that in itself sets you up for severe low back pain or for significant low back pain 10 years down the line at a rate of about 30 to 40% of patients. So that's very significant. So the question is, once you have a lumbar disc herniation, especially if you have an operation? Is there anything that you can do to hopefully prevent that from happening, to minimize the risk of these problems happening down the line? So, and this is just a study showing that there is, in fact, there's a 30 to 40% chance of patients having moderate to severe low back pain at 10 years after having a lumbar disc herniation, regardless of having surgery or no surgery. Just to compare that to patients who didn't have a disc herniation, the point prevalence of low back pain is about 10 to 12%. So 30 to 40% is very significant. So we looked into annular fibrosis repair, because we think that is probably the main mechanism how patients with a lumbar disc herniation then go on to deteriorate. You do a very successful operation, you cure them from the sciatica pain, but they develop progressive disc degeneration and maybe a recurrent disc herniation, and that's how they develop then the significant incidence of low back pain 10 years down the line. And the problem is with the disc herniation that it's very, very difficult to heal up. Biologically, there's no vasculature there, and it's very hard to really get disc material to heal up over time. So people have looked at implants, and the most promising implant right now is probably, based on the studies, is probably Barricade, which has just been FDA approved and is being used, I know, in Europe a lot, maybe also in South America, I'm not sure. The problem with that type of implant, though, is that it's a short-term fix, but it may not really it may not really promote long-term healing of the annulus. So we really need to look at long-term results to see if it really allows us to cure the annular defect and therefore prevent really long-term disc degeneration. In terms of recurrent disc herniation over the first few years, there's definitely a significant improvement with the Barricade. But again, the problem is down the line. What's going to happen at 10 years? Are we going to be able to cut down that rate of 30 to 40% significant disc degeneration and low back pain? So at the end, I just want to talk a little bit about the research to give you an idea as to how we're trying to affect that. So we're working on a research project here where we're using a biological, a tissue glue, to repair the annular defect in those. We're doing it in animals right now, but the idea is obviously eventually to do this also in patients. So we do a microdiscectomy in these patients, and then we seal the annular defect here that's being created during the surgery with a tissue glue that we inject with or without cells, and hopefully that will then prevent further disc degeneration and recurrent disc herniation. So we published that, for example, recently in a paper in Science Translational Medicine in sheep. And what we did in these sheep is we inflicted a disc injury. We removed part of the nucleus and the annulus. We then used HA to replace the nucleus, and we used collagen, cross-linked collagen to close the annular defect. And in these animals, we saw very, very promising results. If you look at the damaged disc here, there was a black disc, a complete disruption of the disc. And then if we use the combination of the new replacement and the annular repair, we had almost normal MRI findings and normal histological findings in these animals. So this is very promising, and we're going to certainly pursue this further with follow-up studies in animals, and hopefully at some point get also into clinical trials. Now, I just want to talk to you briefly about something that we've been working on for total disc replacement, especially in patients who have cervical soft disc herniations. So we've used the same technology using highly concentrated collagen together with scaffolding materials to create constructs that we can implant into the cervical spine. This is such a construct. There's an absorbable rim filled with collagen and cells, and we're working on pig studies right now. In pigs, we're doing total discectomies and replacing them with these cervical spine implants, and we're getting outcome studies, obviously, in these pigs for now. So that's really how far I wanted to go, and this would be a perfect patient, a patient with a cervical soft disc herniation, spinal cord compression, where we insert the implant and then treat those instead of having to do a fusion or disc arthroplasty. And hopefully we'll get there at some point. So the purpose of the talk was really to give you an overview over the biological treatment options that we have for disc degeneration. I think the most promising is really at early stage, patients with low back pain and disc degeneration at a relatively early stage is autologous bone marrow, most likely from bone marrow stem cells most likely from the bone marrow. And annual repair, I think, is very promising. Total disc replacement with tissue engineered constructs is in the future, but I'm sure we're going to get there hopefully within the next 5 or 10 years. So that said, I want to finish up and thank you all. My research team will help me put together this talk. And again, thank you very much for your invitation. And this is a terrific course that you're doing. And I hope I'll be able to follow this over the next few weeks as well. Thank you.
Thank you, Roger.
Thank you, Dr. Roger. There is one question from the audience.
Sure.
Rodrigo Medeiros, he asked about how is going to be the survival of these kind of cells that are implanted in the interdiscal space. What about the ambient, about the environment of this cell because of the plateaus? What do you think about how is going to be the survival of these kind of cells?
Yeah, I think that's a good question because the concern is that there's not a lot of vasculature, and the disc itself is a very hostile environment to really promote biological tissue growth. We have seen, however, in experiments that we did for annular repair and also for total disc replacement using biological implants, that those cells survive and that the structures actually integrate into the end plates. So I think that this is a very important concern, but experimental results from animal experiments show that there is integration of those cells and there is survival of those cells.
Nice, very nice. And another question from the audience to Alexandri, great friend. He's asking about other reasons for low back pain, because we talked a lot about the disc, but what about the other structures like the facets and everything? There is any kind of treatment like biological for these areas too, or only the disc?
Yeah, I mean, people use, for example, PRP for facet joint disease and for other, I think that's all, that's all very, very experimental. And I think that if you engage in, I think as a spine surgeon or a spine doctor, if you engage in treating these patients, obviously you got to make sure that you work with a team of interdisciplinary specialists. So you can't just decide by yourself as a spine surgeon, oh, I'm going to inject cells into that disc. I think you got to make sure that you look at the clinical exam, you exclude the facet joints as a pain source. You do maybe trigger point injection, make sure the pain is not coming from the muscle. It's a diagnosis of exclusion. And once you exclude everything else and you have a reasonable suspicion that the pain is really coming from the disc, then maybe you can consider using biologics for the disc. In terms of the biologics for other than the disc in the spine, it's very preliminary. I know in other orthopedic areas, biologics are being used very abundantly and I think fairly successfully. In the spine, other than disc, I think it's a little bit it's not proven.
Nice. And another question about if you have an experience with spinal cord injuries, if you have like any research on this area or only on the degeneration of the disc?
Yeah, you know, that is a very exciting area of research. It's totally different. You know, it's a totally different area, and there are great experts out there who would make great speakers about spinal cord injury. You know, Rick Fessler does a lot of work on that, and many others. And I wouldn't be able to comment. It's way too complex, but it is a very exciting area of research.
Nice. And one last question here. What do you think about the degeneration of the disc, Dr. Hartl? Do you think it's more biological or more mechanical? Because of all the knowledge we are improving about the sagittal alignment and everything, what do you think about the cause of the degeneration? Do you think it's more biological or more mechanical, or both?
Well, I think certainly a combination. I think a lot of it is genetic. You know, there's clearly a genetic component here. If you look at your patients that you see in the office, so I think a lot of it is there's a genetic. It runs in families, and then there's a combination of biologics and mechanical. I mean, there's certain occupational hazards, smoking. So I think it's a combination. You know.
Okay, so I think we are going to move to the another lesson. Thank you a lot, Dr. Hartl.
I think Dr. Pimenta had another question, Murilo.
Oh, please, Dr. Pimenta, please.
Dr. Pimenta have a question. He's raising hands in the camera.
Oh, so I can't see him. Sorry.
Yeah, I don't have the thing of raising hand on my options here. But anyway, Roger, very good review on treating disc, treating the annulus. We all know that the majority of degenerations comes from end plates and circulation of the end plates. Don't you think that is a waste of time trying to fix a disc when the nutrition that comes from the end plate is broken?
Yeah, you know, I think, Luis, I think that's a good point, you know, and there have been studies trying to incorporate the end plates in, like, for tissue engineering, for example. There are groups that study, instead of just focusing on the disc, they're trying to replicate the end plates as well. And they actually use, they grow in vitro, the disc plus the end plates. And if you look at the study that was done in Hong Kong with the transplant study, you know, where they transplanted the disc, they transplanted the disc in humans together with the end plates, and I assume that was done for that reason. And I think you've got a good point. I think that's something we have to certainly keep in mind. But it obviously it then becomes a totally different intervention. You know, because you can't, then you're really talking about a pretty big operation, because there's no way to regenerate the end plates per se without really replacing them. But I mean,
what I mean, sorry to interrupt, Roger, but what I mean is when you start seeing the end plate degeneration, there are studies on knees. They inject bone enhancers to restore the bone itself. It's not really removing the end plate, but adding some bone growing material to restore the end plate and maybe restoring the circulation, because the disc is a vascular structure. All my experience on nucleus replacement, the big issue was the annulus. There is nothing that you can do once the annulus get interrupted. Annulus is a very difficult structure to restore. So sorry, but I don't believe in any annular repair. I don't believe in any nucleus replacement or things around that. And biologics on the disc without treating the end plate, that is the first reason to the degeneration, for me doesn't make sense.
Yeah, I think.
But nobody knows, right?
Yeah,
it's just guessing.
Yeah, I think you got a very good point, and it is an extremely challenging biological problem, and we're certainly not at the point where we can claim victory. All we're doing is trying to, gather data, and there's some partial successes, but you're right, it's a very, very difficult problem, and your point is perfectly well taken. I think the end plates are difficult to study, are difficult to repair, and that may be the downfall of the whole technology. We'll see.
Dr. Roger, can you please click an